Fujifilm's been doing MR for the last 35 years. And to kind of get an idea of what happened is Hitachi and Fujifilm actually combined about 2.5 years ago to bring these wonderful developments to life for you. And we do things a little differently at Fujifilm. We have a different passion, we have a different why. And it really is about solving problems and solving problems in your practices. And that's why we're here. And so I'm gonna start off with a simple question. Everybody, who has an iPhone in this theater? Okay. Who has the original iPhone 1 still in their pocket? Nobody, right? If I was gonna say you have an iPhone, probably we'd make the assumption that you had an iPhone 10 or above, 11, 12. Who's got the 13, 14, okay, 15, 16? Oh, you win, okay, you're at the top. 17. No? He's thinking about it, okay. But when we say things like, do you have an iPhone, we make an assumption in life that you have a certain level of iPhone. We don't think of somebody having the original iPhone and think it's them. Well, for us at Fujifilm, think of it another way. If you say, do you have a 3T? Well, take a look at the image here. Which one's a 3T? I hate to say this, guys. I've been doing MR long enough that I can tell you that both are 3T. Okay? That is how much our images have changed just in the last, 28 years of my career. Okay? So really, when you think about the difference, you think about the difference in iPhone technology. Think about how amazing that original iPhone was. Then think about what your current iPhone can do. Well, when you look at the difference in the systems, you look at how much they've changed. Well, at Fujifilm, we are the last bastion of OpenMR. We're the last ones that are still creating beautiful images out of OpenMR. And when you look at how far we've come in that same time from that original iPhone 1 to the current system, look at how far the system has come in design. But also look at how far we've come image quality-wise. We aren't your father's Oldsmobile. We are no longer the OpenMRI of old where you're kind of guessing where the neuroverts are or where everything's at. You're really seeing image quality come through. And then when you look at what we can do with 1.5 as well, and we have a brand new system that we announced 2.5 years ago, almost 3 years ago now, called Synergy, that has taken it to a whole new level. We're now with our DLR Rise technology, our AI, our first of our 3 AIs that we'll be talking about here in a moment, we're getting it down to about 52 seconds. I can tell you back in our clinical science lab, we're running ACR appropriate scans like the lumbar in 30 seconds, 32 seconds, and flying pretty well. Well, now with OpenMR, we can use that same technology, that same AI technology to bring out even better image quality into the image. And you're looking at now, in the age of fast MR, even OpenMRs can now scan in less than 10 minutes. So now, how does this work? Well, we've heard it from GE, we've heard it from Siemens, we've heard it from Philips, you heard it from us about this wonderful denoising that we can now bring. So now you can bring 50 to 60% more SNR. But my question I have for you as radiologists, for you as technologists, for you as scientists is how do we want to spend that 50 to 60% more SNR? What do we want to do with it? Well, we can scan fast. That goes without saying. But what if we could do it even better? So we have 3 technologies that we've brought into our Synergy, and then DLR Rise to our Velocity, which Dr. Kennedy here will be speaking about here in a little bit. But DLR Rise removes that 50 to 60% of that noise through a DCNN, a deep convolutional neural network. And when we blow up the images, it's one of those things where you say, how can you look at how fine a jewel is? You want to make that jewel large. When you go looking for a diamond, you look for that cut, clarity, color, and seeing how beautiful it is. Well, blow it up. Take a look at the images up close and see what we're really doing. Now, our second AI is called DLR Clear. And this is our super resolution tool. And it's removing that truncation out of the image, bringing that clarity that we've only dreamed of seeing to the image. And then seeing how it cleans up the image as well. But also bring that clarity also to 3D, not just 2D, but also 3D. So our 3D Tiger, the equivalent of Vibe or Lava for GE and Siemens, also to be completely clear. But now this last year, we brought out our third AI, and it's DLR Symmetry. And this is the ability of our AI to film the other half of K-space when we use half echo. And one of the trade-offs of half echo has always been, well, if we scan with half echo, yeah, we get a faster scan. But there's always the trade-off of having a noisier image. Well, now, with our DLR symmetry on our Synergy, we're now able to bring the clarity in just as little as 10 seconds for a breath hold, bringing compassionate care to all. But then when you bring it to diffusion, you bring DLR symmetry to diffusion, we're used to seeing that kind of foggy, I wish we could see it, the prostate. But now with DLR symmetry, we're able to bring that B1500 into clarity and really bring that diagnosis to the patient. Well, when we bring it into diffusion tensor imaging, DTI, now we're able to see even more fiber tracks to bring it out even farther, to bring a clarity that hasn't been seen before, all from a 1.5. Now, the last innovation I want to share with you before I turn the podium over to Dr. Kennedy here is we believe so much in sustainable growth that we saw the future that we need to give you an option to have a zero helium system in both the zero helium Synergy and zero helium Smart. And we did it a little bit differently than everybody else. We said, let's make the system have no helium, only use gaseous helium so we can have a much better environment so you don't have to worry about your system in the near future. And so we brought zero helium to the masses, and it comes through direct cooling. And as you've experienced, especially, I hate to say recently, with the cost of helium now going even farther up, we're giving you a sustainable solution that makes it very simple for you to site the magnet and not have to worry about the risk management, the installation limitations of having a quench pipe and having low ceilings, but also never having a red quench. But we've all had these accidents before where things have stuck to our magnet, and we said, let's make it a little bit easier for you. So conventionally, with a normal superconductive magnet, we spend about 2 days to get an item off our system. Well, now with Echelon Synergy Zero Helium, you can now ramp down the magnet in 70 to 90 minutes, pull the item off, be ramped back up in 60 minutes without the aid of your engineer coming, all underneath your own control, and get you back up and working. It's very, very simple and easy. But then we took it one step further. Your image quality will not change between the ramp down and the ramp up. So it means you have no need for a service engineer to come out and take care of you, making sure that you can get back to patient care as fast as possible. And that's our Fujifilm pledge to you, is to get you back and functional. And that's zero helium as a whole. So no need for anything. So to continue on, that's the end of my little piece. The next little piece that I want to share with you is we've brought in Dr. Brian Kennedy with University Radiology Group, and our friendship started years ago. They actually had one of our older systems almost 20 years ago of an Aris 1, then an Aris 2, then an Aris Elite. And Dr. Kennedy's brought a unique perspective of what the Velocity can do for you and what the Velocity has done for his practice. And I will turn this over to you. Thank you, Dr. Kennedy, for your time. And here we go.
All right, well, thank you for that introduction, and thank you everyone for coming here to listen to me talk about a subject that, I know for a lot of people, open MRI can be considered a taboo, right? I know for me in my own, clinical training, open MRI was something that was kind of, looked down upon. It was the test that you got before you got a real MRI. But tonight, over the next 30 minutes or so, I'd really like to try to change those assumptions. I know thanks to what we've been doing in the open MRI space, thanks to the Velocity 1.2 Tesla open MRI, I'd like to hopefully change your opinion of what we can do. So just a little bit about us and our background. So University Radiology Group, we're a large multi-specialty physician-owned private practice in the United States. We do about 2.1 million exams per year. About 2/3 of that is in our hospital practice, 1/3 of that is in our outpatient imaging offices. And in our outpatient practice, where I serve as the chair of clinical office operations, we do about 110,000 MRIs a year, about 400 MRIs a day if you do the math. And I have asterisks next to our offices and MR units because we're constantly growing. By the end of this year, those numbers will be a little bit higher. So one thing we really pride ourselves on at URG is being vendor neutral, right? So these are the 5 big vendors in the United States by market share, and with the exception of one of them, we utilize all the different vendors in our system, and it really allows us to use the strengths of some vendors for certain applications and other vendors for others. But obviously tonight, we're going to be talking about what we're doing with Fujifilm and the Velocity open MRI system. So just a little geography lesson, since this is an international conference and maybe not everyone's familiar with US geography. So University Radiology, we're based out of New Jersey, the tiny little state outlined in red in the right corner of the screen here. And New Jersey is situated between New York and Philadelphia metropolitan areas, so some of the more densely populated areas in the United States. And New Jersey itself as a state is the most densely populated state in all of the United States. So keeping that in mind, when we think about where all our offices are located throughout the state, we kind of concentrate ourselves up a little bit more towards the New York City area, but we've expanded, in past years to include offices outside of, Philadelphia and down the Jersey Shore. And all of these offices have, nearby hospitals where we have a sort of dynamic relationship where, we read studies for their patients. They sometimes will send their patients to our outpatient imaging centers. And a lot of these hospitals really consider themselves to be centers of excellence, right? A few of them are National Cancer Institute recognized cancer centers, they have level 1 trauma centers. Some of them do professional collegiate athlete, care. Some of them have residency programs, research, and what that all means is, we really strive to provide not only excellent, reporting, but also excellence in image quality. This is what these, referrers are looking to us to give to them, and it's really important to us when we're making our decisions on, what kind of hardware we're going to put into our offices. So, again, being an international conference, maybe if you're not from the United States, maybe you're not familiar with New Jersey. Maybe what you know about New Jersey is the stereotypes around New Jersey, right? It doesn't get a good rap on the national or global stage, right? So from the media, maybe you know about it through, mob activity. Maybe you know certain kind of party goers that go down the Jersey Shore, right? Maybe you've flown into Newark Airport on your way to New York City and you saw all the refineries and all the industrial plants in the area. Or maybe you heard old stories about, trash and waste washing up on the New Jersey beaches, or maybe you happen to follow American football and you know that the worst American football team for the last 15 years plays its games in New Jersey. But the reality is, right, New Jersey is so much more than that, right? It's big, open, outdoor spaces, lots of hiking, beautiful shore towns, lots of farmland. New Jersey gets to be called the Garden State, and a lot of historic sites and universities. Unfortunately, not much can be done about the bad American football teams, though. Similarly, open MRI comes with its own set of stereotypes, right? For me, this is the kind of image that I would traditionally think about when I think about open MRI, right? Something that's very noisy, something that's low SNR, weaker tissue contrast, all in all combining to make a very low resolution image, right? So I'm a musculoskeletal radiologist. I live in the world of small structures, right? Menisci, labrum, cartilage, ligaments. I have to be able to see those things to make a diagnosis, and the clinicians want to see those things too. And it can be very challenging when you're faced with low resolution images, right? Some other stereotypes to overcome those issues with low SNR, we might do longer image acquisition times. Some of our older magnets for just a simple lumbar spine or knee might have had 45 or hour-long blocks in order to get, just image quality like this. These older magnets have lower gradient performances and limited coil options. That just means that some imaging techniques or sequences just aren't available to you or much more challenging to perform. So it all kind of raises the question, if this is what you have, why were we even offering this, right? Well, claustrophobia is probably the biggest reason, right? Patients don't want to get in the tube. And it's estimated to affect about 2 to 14% of all MRI exams annually. And globally, that equates to roughly 2 million scans a year. Now, in our practice, we're doing a little bit better than that 2 to 14%. We're doing about 1,000 exams per year are affected by claustrophobia. But that's 1,000 exams still that are either terminated prematurely because the patient bailed from the scanner early or was moving around and resulted in significant enough image quality degradation that we had to call them back for additional images. And all of that means delays in patient care, right? So when we think about this kind of image quality and we're presented with a sample case, it becomes a little bit of a challenge to think what we're going to do next, right? So the 60-year-old female, long-standing shoulder pain and recent acute exacerbation, she's severely claustrophobic, will not get into a conventional closed magnet. The pain is severely limiting her ability to perform her activities of daily living, and she's got a strong referrer preference for, the referrer has a strong preference for conventional MRI over open MRI because he's used to the upright, open 0.3 Tesla unit that's down the block from his practice that all his patients go to. He doesn't want to send his patients there. So what are our options, right? Well, we could do a conventional MRI and we can do it under sedation. All right, we'll unpack that in a little bit. We can do an ultrasound. I do a lot of ultrasound in clinical practice. It can be good, but there are some significant limitations. Big one, can't see inside the bones with an ultrasound. You can do a CT arthrogram, but you don't have the same tissue contrast that you get with an MRI. Also, invasive tests, right? I gotta stick a needle into someone's joint and inject dye. Low risk, but not no risk. And then open MRI, always an option. So why not just sedate everyone, right? Why put them through an open MRI if this is what you're gonna get? Well, there are patient risk factors for sedation, right? There are long wait times for scheduling for sedation. Paradoxically, you can have increased motion in some body parts, and there are operational challenges around offering sedation in an outpatient imaging practice. So let's unpack that. So risk factors for sedation. In the US, probably the biggest risk factor is gonna be obesity, right? Obese patients don't make great sedation candidates. But then other health problems like cardiovascular, respiratory problems, sleep apnea, those kinds of patients might not be adequately sedated or safely sedated in an outpatient setting, right? So in this example, this was a 30-year-old female who had a mass in her mouth, right? And from the scout of the CT that she had before she ultimately went for MRI, we can see she's a little bit on the larger side, right? This is not a patient who would have done well in an outpatient sedation case. So instead of doing that, what if we could offer her a better alternative in the open environment to scan her? And that's what we did. We scanned her on the Velocity, and what we see here, axial T2 fat saturated image. We can see T2 hyperintense mass around the right mandible. We do see a little bit of susceptibility artifact from the dental hardware, but keep in mind, we are at a slightly lower field strength, right? So that artifact is actually not as bad as it might have been in the conventional 1.5 or 3 Tesla scan, right? We see good fat saturation on the image. On post-contrast, T1 Dixon, again, enhancing mass about the right mandible, and we can see the susceptibility artifact related to the dental hardware, still manageable, not obscuring our mass. I think for me, if you showed me this image in a vacuum and asked me where it was done, I would say, yeah, probably done on a pretty good conventional scanner. I don't think an open MRI would come into my mind when I saw this image, right? Other problems with sedation, long wait times. And as we think about the long wait times, we can sort of stop thinking about this image quality and start thinking about this image quality, right? Busy slide, but this is just an overview of our offices and the wait times for the MRI at a single point. I'll just point out the bottom line, sedation. Only one office is offering sedation. What's the wait time in days? Well, if you want to get a conventional MRI with contrast, non-contrast, 5 days, arthrogram, okay, a month, that's not great, but but a sedation MRI, 90 days, okay? And that's, that number goes up and down. I've seen it as low as 70. I've seen it over 100, right? So these are patients who are waiting, 3 months to get their scan done. That's delays in care, delays in treatment, and what's really problematic is, we originally offered sedation. The target audience was pediatric patients and patients with special needs, right? But over time, claustrophobic patients have really captured a lot of those appointment slots. Okay, other issues, paradoxical increase in motion in some body parts. So this is an exam that was done under sedation on a 3 Tesla magnet. Patient was sedated for an MRA, and what we see here, we see some characteristic stair-step artifact from patient motion, right? What happens when a patient's asleep, right? They snore. What happens when you snore, right? You get vibratory motion in the pharynx, right? Some people who are asleep, right, they maybe not, they maybe roll around, they kind of move around. It's hard to tell them to stay still, right? Poorly controlled swallowing, another issue. Imagine trying to do abdominal imaging and telling people to, do breath holds when they're asleep. Very, very challenging. The best sedation candidate is one in the ICU who's intubated, sedated, and paralyzed. They're not going to move at all. But in the outpatient setting, we can't really do that. Again, thinking about those wait times, this patient waited 90 days to get the scan done when alternatives are possible. And you might say, well, just look at the source data, right? The source data is going to be good. Well, the source data is motion degraded too. And the other thing is the 3D recons, the referrers really, really like these 3D reconstructed images, right? They're kind of nice overviews for them. They can serve as operative or procedural planning images. So to refer, that 3D is not very helpful. Contrast that with what we can do on the Velocity, right? This is, again, very high quality imaging of the neck and central head vessels done on the Velocity in the open environment. And lastly, a lot of operational challenges around doing sedation in an outpatient setting, right? You need contracts with anesthesiologists, you need special equipment in your MR room, you need special staffing, you have to increase your exam appointment times to account for all the room turnover. You have to then scan less patients because of that. And that all adds up and makes it challenging. We actually have some other practices in our area and even some hospitals that have stopped offering outpatient sedation partly for these reasons. So all that together really means sedation is not a silver bullet. There needs to be a good alternative for handling these patients, and the Velocity really can be that alternative. We don't have to compromise on image quality. And for a long time, before the Velocity, we had open MRI units in a few of our offices. We had some 0.3 Tesla units, we had some 0.7 Tesla units, but we had them more out of necessity because there was a demand for them. We were never really fully satisfied with what we were able to get from them. And as they aged out, eventually we had no open MRI systems. We just kind of let them age out as they got older. And then when Fuji came to us and said they had this new system and that it was going to kind of revolutionize the way we thought about open MRI, we kind of dove right in. We put it in 2 of our offices, and in both those offices, it's actually paired with a conventional closed magnet, wide bore 70 cm, which is nice because you can, if you have a patient who thinks they can get into a conventional magnet and then freaks out, if the stars align, you can just walk them right over to the open unit and say, come on over here, and we'll get your scan done. So we've had that for the last few years, and we were very satisfied with the quality of the studies we were getting from there, that we ultimately, at one of our offices with an aging 1.5 unit, we actually pulled that unit out and replaced it with an open unit. So in that office, that unit now stands as a standalone open unit to kind of increase our coverage to more of the northern parts of the state. And this is the Velocity in our freehold office. As you can see, it's got the classic open design. It's nice. The patient can turn out. They can see light coming in from the window. The nice light room. Very soothing environment for our patients, right? And so what I want to do now is I kind of want to transition to talk about the, some of what Mani was talking about, what we're doing behind the scenes that's letting us get the quality of the images that, I've started showing you. A big part of that is definitely field strength, right? Being at 1.2 Tesla in the open environment is certainly helpful, right? But there's a lot going on under the hood as well that lets us get high quality imaging, right? How we get from images that, once looked like this to images that look like this. All right, a big part of that is the IP rapid and the DLR process, right? Essentially a combination of parallel imaging and iterative processing and AI, right? So we all know that when we do parallel imaging to increase the acceleration and decrease our scan time, right, we end up with characteristic artifact, namely aliasing and increased image noise, right? With IP rapid, we can actually deconstruct the image, extract the noise, reconstruct the image, and then repeat that process to clear the image of the noise and end up with a more optimal image. So an example of what that looks like, this is a healthy volunteer. This is a T2 axial image of the brain on the top, and then we have the zoomed in area of interest outlined in orange here. And as we increase our acceleration factor from full sampling to acceleration factors of 2, 2.5, and 3, without doing anything else, we can see we start to get increased noise as evidenced by the kind of grainy appearance in the in the CSF and the grainy appearance in the white matter. But when we do the same process but apply IP rapid, we can see that as we increase our acceleration factors, we do not have the same increase in image noise. And so what does that mean? It means faster scans without having to compromise on SNR. So then that output image from the IP rapid process is then passed through the DLR algorithm, which, DLR is the AI system, and like a lot of these AI systems, it's a little bit of a black box in terms of what's actually going on inside that network. But I can tell you the network itself was trained on over 1.3 million images from different tissue weightings and different body parts. And ultimately, the output is one that is significantly decreased in noise. So what does it look like when we put those two things together? So again, healthy control patient, this is an axial flare of the brain, right? When we do parallel imaging with acceleration factor 3, we can see increased image noise in the central portion of the image. When we apply just the DLR, right, we see a significant decrease in the image noise, overall smoothing of the image, still a little bit, but definitely reduced from before. When we apply IP rapid, we can see that that noise is significantly reduced, though it doesn't have the same global reduction in noise to create that smooth appearance that the DLR does. But when we put the two of these together, we can see a truly high quality image, significant decrease in noise, overall smooth looking appearance, and done in a fraction of the time, right? So it means we can scan faster and still get really high quality imaging, right? And it's not just software and post-processing, right? We can actually take advantage of the open environment, right? And we can use lateral table movement to place off-axis body parts closer to isocenter. So how would we do this in like a traditional closed environment, right? We usually, if we're scanning a hand or a wrist or an elbow, ideally, put them Superman on their stomach, arm up, right? Well, after 10, 15 minutes, holding that position can get pretty tiring, right? I had a thumb MRI done 6 months ago when we were breaking in a 3T unit, and after 10 minutes, I was really feeling it, and I consider myself to be kind of fit individual. And, you can imagine an older patient or an injured patient trying to hold that position. So what do you do for them? Well, maybe you try to shift them in the bore, right? And you try to get that body part closer to isocenter. But what if you've got a larger patient? You're trying to stick them in a 60 cm bore, or even sometimes the 70 cm bore. That can be challenging, right? With this system, right, we can move the table laterally, taking advantage of that open architecture, and place that body part much closer to isocenter. And that's how we're scanning all of our patients at URG when they have their upper extremities imaged in the velocity magnet. So just an example of what this looks like. So this was an 84-year-old female who had an injury after a fall. She was having her elbow done at 3 Tesla, and we can see based on the scout that her arm is at her side. And what do we get when we look at her coronal PD fat sat and her axial T2 fat sat? We see poor fat saturation, right? Arms off isocenter, we have poor fat sat. Some of this is edema, some of it's poor fat sat. Can you tell which is which? Challenging, right? This is a challenging case to read. Meanwhile, on the velocity, we scanned a separate patient with their arm at their side. No problems with fat sat, right? Very easy to see what's going on in the common extensor tendon. We have a high-grade tear, and we can see pretty robust fat saturation on this image, right? And it's not just lateral table movement, right? They have higher order active shimming technology to also create a highly homogeneous magnetic field and really aids in fat saturation to have robust small field of view fat saturation, very strong large field of view fat saturation. And so what I want to do now, I want to just kind of walk through a few more sample cases from our clinical practice and just show you some of the image quality that we're getting with this magnet and really, again, try to change your perceptions over what is possible in the open environment. So this was like a 40-year-old male with lateral knee pain and locking after an injury. And so for me, when I'm looking at an EMRI, what do I want to see? I want to be able to delineate the cartilage, right? I want to be able to delineate the menisci. I want to be able to delineate the ligaments. And as we come anteriorly, right, we can see a pretty nice medial meniscus. But when we look at the lateral meniscus, you can pretty clearly see that there's abnormal signal and abnormal morphology. And we can even see a little meniscal fragment displaced into the intercondylar notch in this patient with a bucket handle tear. And what I also love about this image is you can actually make out the two individual bundles of the ACL You need high quality imaging to do that. Otherwise, the ACL is just going to look like a little bit of a blob, right? Nice delineation of the articular cartilage overall, very high quality. I like this case because I fooled even myself. I pulled this case off one of the centers where we have both a open and a 3 Tesla magnet, and then I anonymized it and I put it in the presentation. And then like a month later, when I was going through it, I looked at this and I thought, I really hope I didn't accidentally pull one of the 3 Tesla images because I was that impressed. So I went back, confirmed that indeed this did come off the Velocity. And what we see here, very nice cartilage delineation. We can see cartilage defect. We can even see a little bit of a delaminating cartilage flap with fluid undercutting the cartilage. We can see a little bit of subchondral bone marrow edema in the medial femoral condyle. And when we come anteriorly, you can see the displaced cartilage fragment. Again, very nice image quality. Here's a sagittal T1 image of a man being evaluated for a hand mass at the proximal interphalangeal joint. And we can see nice delineation of this intermediate signal intensity mass. Notice the trabeculation of the bone on the sagittal T1. When we go to the sagittal T2 fat-saturated image, these masses, this is a giant cell tumor tendon sheath. They're often kind of challenging to see on fat-suppressed images because that sort of intermediate signal intensity mass often blends in with the suppressed subcutaneous fat, but still very nicely seen. And what you can also see very nicely are the small parts, right? The volar plates of the joints. You can see the flexor and extensor tendons quite nicely. In our practice, we've stopped doing small part imaging on some of our older 1.5 and 3 Tesla scanners because they don't produce the quality of imaging that we want or that our referrers want. And we don't have to do that in the open environment with the Velocity. We can still do small parts imaging and get really high quality results. And on the coronal here, you can just see the mass enhancing. And again, nice delineation of the 2 individual slips of the flexor tendon. Here we have an axial phase balance gradient echo, and a sequence we would use for neuro applications. Again, very nice contrast. You can see nice delineation of the individual cranial nerves and the inner ear structures like the semicircular canals and cochlea. Sagittal lumbar spine sees significant disc disease here at L4-5, causing significant mass effect on the cauda equina nerve roots, so much so that we can actually see this like compressed curly Q appearance of the nerve roots. Here's an axial T2 star gradient echo image of the cervical spine. We can see a pretty large disc herniation exerting mass effect on the cervical spinal canal. Notice that we can actually nicely delineate the gray-white differentiation of the cord. We use these T2 star sequences here because we like to look at the susceptibility artifact created by the bone. It helps us differentiate bone from disc in terms of these herniations. On the sagittal T2, we can see that same disc herniation exerting mass effect on the cord. And just for comparison purposes, this is the equivalent sequence done at 3 Tesla, right? One thing I want to kind of draw your attention to is if you look at the posterior elements, right? So posterior elements are going to be bone, a little bit more susceptibility. Notice like the difference in the blooming between these two. Now imagine, an osteophyte or a bony projection going into this really small space of the foramen, right? One of the benefits of being at a slightly lower field strength of 1.2 Tesla, you don't have this blooming artifact as bad as at 3 Tesla. This might actually, over-exacerbate the degree of stenosis or overestimate the degree of stenosis. And we can do large field of view body imaging too. This is an axial T2 fat saturated image of pelvis for workup of a left adnexal mass. And you might say, hey, check your T2 weighting. This mass isn't that bright, but I'd draw your attention to the bladder where the fluid's hyperintense. And on the axial T1 Dixon fat suppression, we can see the mass is T1 hyperintense, and this ended up being a patient with endometriosis. On post-contrast subtraction, we can see nice peripheral enhancement as well as enhancement of the uterine tissue and the other internal pelvic structures. In the abdomen, this is another large field of view large field of view image. We see a patient being worked up for a large left lobe liver mass. This ended up being a large hepatic adenoma. I really like this one because this is the same patient done exactly 1 year apart or close to 1 year apart. One of these was done on a 1.5 Tesla unit. One of these was done on the 1.2 Velocity unit. All right, I can tell you that one of these took 1.5 minutes to obtain. The other one took 2 minutes and 30 seconds. Image quality-wise, I'd say they're very comparable. I'd say I have one that I prefer. I won't pull you guys, but the 1.2 is the one here on the left. And then on the sagittal, this is a sagittal stir, similar longer image acquisition time. I think in this case, it's much clearer to me which one I prefer. That's this one on the left, and this was the one done on our velocity unit. All right, so I want to take just like the last 5 or 10 minutes to talk about some of the, the operational benefits that we get from this magnet, right? I often like to think about it, with this magnet, we can have open MRI comfort and marketing with conventional 1.5 throughput and image quality. And hopefully, some of what I've shown you is already proven the image quality perspective, all right? But what about the throughput, right? So this is just an outline of what our scheduling framework looks like. We schedule in 15-minute blocks, right? And so you'd think if you have a 15-minute knee MRI, right? What's the best thing you can do? Well, I'll just slide that 15-minute knee MRI into a 15-minute appointment, then I'll just load my day with 15-minute knee MRIs, and we'll have a great time. That's a great way to run a practice if you hate your technologists, okay? Because what this doesn't take into account is things like room turnover time. It doesn't take into account things like the 80-year-old patient who showed up in a wheelchair and needs to be transferred to the MR safe wheelchair, and then needs to be transferred from that to the table, and then you got to do that all over again. It doesn't take into account the clerical time that the tech has to do between scanning. So as you approach the upper limits of your block time, instead of just hoping that your tech can do it, right? You extend it, right? So a 15-minute knee MRI might fill a 30-minute block, and you can get creative, right? You can do things like double book patients, so you're not wasting all this time. But just from a framework of how we want to think about how these exams are scheduled, but think about it in terms of what kind of block do they take. So when we think about our overall exam time, and this is kind of averaged out throughout the practice, right? Don't think about time, right? Think about it in terms of what kind of slot is this going to take up. And really, pretty much uniformly, we're scheduling all of our velocity appointments in the same time slots that we would schedule patients at 1.5 Tesla, right? So we're really trying to achieve that open MRI comfort and marketing with conventional 1.5 Tesla throughput without sacrificing image quality. All right, lastly, that marketing component is really important. So this is back to the map in New Jersey. This is where our Somerset office is located, and this is just like a heat map based on patient billing data for patients who came to use the velocity magnet, right? And what you see, pretty dense concentration of patients coming from around the office, but you're also seeing patients come from pretty far to utilize this magnet, right? People from all the way down the shore, Philadelphia area. This is Eastern Pennsylvania. This one's my favorite because as someone who does the drive to and from Long Island, not infrequently, this is like on a good day, an hour and a half. It could be like 2 to 3 hours with traffic. Anytime you have to go through New York, it's just a nightmare. So patients, they really seek this out. Some of my clinical colleagues, I was having dinner with one of them the night before we flew out here, and we were talking about this, and they said, if there's one request that patients have when you tell them you need to get an MRI, it's, can I have it done in an open unit, right? They don't really, the patients might not care as much about 1.5, 3 Tesla, right? But the ones who are, most invested, that's what they're invested in. This is our Freehold office, and again, similarly, you see Freehold's kind of considered a shore town, so you see a big draw from the shore area, but then really all up and down the I-95 corridor, you can see a lot of our patients come from quite far to use the magnet. And they like to tell us about it in our reviews. I could probably fill up a bunch of slides with these, but I'm not going to waste your time with that. But overall, really, really positive patient experience. And I do have to kind of take a second to also recognize, our technologists, right? They're a big part of making the experience really great for the patients. And, if you take the time to read through these, you'll see the techs often get, really commended for helping patients go through the MRI process. So, it's one thing if the patient's happy, it's another thing if the radiologist and the clinician is happy, right? Because that's ultimately, at the end of the day, who the scans are being, done for, right? They are the ones who are going to need to interpret it. So let's go back to that sample case from earlier on, right? So we have a 60-year-old female, again, long-standing shoulder pain, recent acute exacerbation. And remember, this was the referrer who really did not want to send a patient for conventional MRI. As an aside, this referrer is like the most particular person I've ever met in my entire life. So eventually, he relented and said, fine, you can go get an open MRI. And we did. She came and had it done on our Velocity system. And what we see here, this axial PD fat saturated image, we can see this is the long head biceps tendon. As we come from inferior to superiorly, we can see it should be living in this biceps groove here. Instead, it's dislocated medially, sitting on the lesser tuberosity thanks to this tear in this tendon here, which is the subscapularis tendon. And we can see fluid in the tendon sheath, edema in the lesser tuberosity. All in all, a pretty painful process for the patient. And after this patient had the study done and I had read it, the doctor called me a few days later and he said, Brian, I'm very confused. I sent this patient for an open MRI. She came back to me. The images say open MRI. She swears up and down she had an open MRI, but I can see what I'm looking at here. I can actually interpret these images, what's going on. And so I had the pleasure of telling him we had a few of these in our fleet and we could, take care of any of his open MRI patient needs. And that's really all thanks to what, Fuji's been able to do with this velocity magnet. So that's it for me. Thanks for your attention.
And again, thank you, Dr. Kennedy, for your time.